Good evening. So we heard excellent talks about the implantation of both AGV and AUDI, and I'll be discussing about some of the tube-related complications. So first thing what we understand when we talk about implants in glaucoma is that it has a long tube which is partially there in the anterior chamber, which is actually bypassing the fluid from the anterior chamber through the tube into the posterior subconjunctival space. So basically there are two components that are there. There is a tube, there is a plate, and this long tube is actually placed in the subconjunctival space. So whether we like it or not, we have a foreign body in the eye, and it is placed in whichever quadrant. There are eye movements which are constantly there, so which makes the tube inside the eye a very dynamic thing. So it is mostly used in difficult glaucomas, all the eyes where you have scarred conjunctiva, and those even in children as a second or a third procedure. It's very important to select your cases very carefully, especially for those people who are beginning to do an implant procedure. I think it's very, very important to choose your case very appropriately, otherwise you will end up having a problem, and if you see one complication and that too a serious complication, you would never want to go back to it again. So you have to be very careful when you're choosing patients. So when you're looking at complications, the complications can broadly be divided into two groups. One is the intraocular pressure related, the second one is implant plate or tube related. So basically we are trying to do an implant procedure because you want to bring down the intraocular pressure, and your conventional trabeculectomies are not helping you. So when we want to decrease the intraocular pressure, like in trabeculectomy, we also have problems of too low a pressure or too high a pressure. So too low pressure, that is hypotony in the postoperative period, is a major complication that we don't want to have, because you know that the problems related to hypotony are terrible. And here, apart from the fact that you will have shallow anterior chamber, you will have iridocorneal touch, you also have a foreign body which is the tube in the anterior chamber. When you have a shallow anterior chamber and tube touching the cornea, you can be rest assured that this cornea will fail. So we need to be very, very careful about this. This can happen most often because of an improper ligature, especially if it is a non-valved implant, or peritubular leakage that can happen if we are using a larger gauge needle. And wound leak, of course, if you have not meticulously closed the conjunctiva. Sometimes you can end up having very serious complication, like either extensive choroidal detachment, which is serous, or hemorrhagic choroidal detachment. If it is not very severe, most often the medical management in the form of increase in the topical steroids or sometimes systemic steroids and cycloplegics itself will help. Over a period of time, just with conservative management, they'll be able to manage. But if you have extensive serous or hemorrhagic choroidal detachment with kissing choroidals, whenever the two surfaces of the retina come close to each other, you will end up having problems, and that is an emergency and that needs to be drained. Apart from draining the fluid, whether it is serous or hemorrhagic, we need to worry about why this happened. Suppose you have a wound leak, that has to be fixed first rather than just draining the fluid, and it may reaccumulate again in no time. So we have to be careful about that. The second thing which Dr. Venkatesh had spoken about is the bleb fibrosis that most often happens with the valved implants. It also happens with non-valved implants, but to a lesser extent. So there are various things that we follow, but one of the things that is very useful is using a aqueous suppressant even in the early postoperative period. One of the reasons why we develop a bleb fibrosis is early reach of aqueous into the subconjunctival space. And aqueous is supposed to be pro-inflammatory, and it tends to develop a very thick cyst. That's the reason why you develop more of a cyst in a valved implant where the fluid drainage is immediate, compared to a non-valved implant where the fluid drainage is usually beyond 40 days. So the early aqueous reaching the subconjunctival space is supposed to induce the inflammatory response. So something like a medical ligature, that means you use the aqueous suppressants in the early postoperative period. Sometimes we start medications like aqueous suppressants, either it is beta blocker or carbonic anhydrase inhibitors, as early as 1 week postoperatively, or sometimes even day 1 postoperatively. If you think the intraocular pressure is adequate, that means anything beyond 7 or 8 millimeters, I can start an aqueous suppressants when I know that everything else is okay. So by doing that, you can actually decrease the amount of hypertensive phase that these patients develop. But in case they develop, it passes off. So we need to be very careful. Also, especially if you're operating and the patient is going to be followed up by someone else, you need to educate them saying that high pressure phase is not failure. high pressure phase tends to develop most often following implants, and this is something which is because of a fibrotic response, and as time goes by, this high pressure phase is going to come down. So that is something that we need to educate. Otherwise, I have seen a couple of patients where they were taken up for a bleb excision or for a second surgery just because they thought it was failing. So we need to be very careful about that. Apart from that, the tube related, whether it is the tube that is present in the anterior chamber or the subconjunctival space, is something that all of us worry about. So the tube block can happen in the early postoperative period, especially because of the blood clot. So depending upon where you try and place your tube, when we are entering into the anterior chamber, however careful you are, especially if you have a very anterior, peripheral anterior synechia, you can end up having a blood clot. Most often these blood clots are innocuous, they really don't trouble. You treat them with a little more of anti-inflammatory and they just disappear. We don't have to go and wash, don't have to do any of those things. In case the pressures are high because the tube is getting blocked, you can treat them with aquasuppressants for a short period. Meanwhile, the clot will disappear. So this is the same patient where there was a clot and in about a week's time the whole thing disappeared. Sometimes we can see the tube being blocked with fibrin. This has to be differentiated from vitreous because vitreous is something that we cannot leave and that's not going to disappear. But in the early postoperative period, if you have fibrin like this, just increase the anti-inflammatory and that will disappear too. Sometimes you can have vitreous blocking the tube. This was a child which I had operated, a phakic child, one-eyed, other eye lost because of retinal detachment. Initially, the baby was doing very well. This was one of the post-operative follow-up, I think around 3 months. I knew this child did not have vitreous blocking the tube because every visit we have been seeing and the pupil was always round and it would dilate very well. At this particular visit, pupil wouldn't dilate and you can see a peaking. You can see a sheet of vitreous going into the tube. So this child required a vitrectomy, and because it was a one-eyed child and had an RD in the other eye, this was kind of a quick thing you had to do because just the vitreous traction itself can lead to posterior segment problems. So if it is a very small tag, you can also do a vitreolysis, not necessarily a vitrectomy all the time. This is another complication that I think we need to really understand. So all of us know that when we are trying to insert the tube in the anterior chamber, we have to make a bevel up. Why bevel up? Because the iris tends to come towards the tube, and even if you have a shallowing of the anterior chamber, the iris cannot climb and go and block the tube if the bevel is up. Sometimes, especially if you're doing it inferiorly, we may tend to get confused, and when you're trying to cut the tube, the bevel can be down. So once you trim the tube, then you have you have trimmed it as per your adequate length. Now you are in a fix because now you have to waste the implant, or you can make it shorter, it becomes too short. So this was one patient who was operated on. We had bilateral tubes done, had a very short tube and the bevel was down and both the tubes were blocked, ended up having very high pressures in the immediate, I think 5 to 6 months post-operative period. So I tried seeing if I can try and revise this. This was operated elsewhere, but then it's not quite easy because you have to use a tube extender and all sorts of things. Again, you're not quite sure whether that will help or not. So I ended up doing trabeculectomy for him in the supranasal quadrants in both the eyes, and he's doing quite well. I think it's about 6-7 years since the time we operated. So it's not that once you do a tube, you don't have another option. If you have superior conjunctiva still left, even at the supranasal temporal, wherever it is, even if 3-4 millimeters of conjunctiva is still spared, you can do a trab in those eyes. Sometimes you can have a silicone oil blocking the tube, which is sometimes very, very difficult, and these are all silicone material. The tubes are all silicone material, the implant is silicone, so it has a very high affinity for the silicone oil. So it tends to sometimes form very funnily an oblong kind of a teardrop-like thing around the tube. Fortunately, it doesn't block the tube all the time, but sometimes you can have the tip being blocked like this. This is very unusual to see just a small droplet. That means that much of oil has gone into the tube and what you're seeing just a little outside is just a little bit there. So most often in patients like this, we tend to do an inferior implant, although we may argue saying wherever you put the tube, if the patient is lying down, the oil is going to go there, or if that is the only way out of the eye, whether it is superior or inferior, oil can still reach there. But most often we tend to do it inferiorly because you want to avoid. But if you see oil in the anterior chamber during the surgery, try and wash it as much as possible. Tube corneal touch is a major problem. And what George pointed out, that in patients, especially with keratoplasty or those with already compromised endothelium, one has to be very, very careful. This was one patient post-traumatic glaucoma. He had a tube surgery done, Actually, the tube was very, very far away from the cornea, but over a period of time, he had this habit of rubbing his eye, number one, which is more common in children. But secondly, once you develop, you can see actually in that OCT, you see the cornea is very thick here and quite thin here. Because of that, over a period of time, the cornea became so thick that it started coming towards the tube, and now there is a tube corneal contact, and he had a tube excision and redirection of the tube to make sure that at least we will limit the corneal edema in that place. This can be avoided by placing a tube in the sulcus, that is behind the iris, or in the pars plana. So tube corneal touch is, again, like I said, it's a very common problem in children. So one of the videos which Dr. Venkatesh showed, where you insert the tube parallel to the iris, is a very good technique. Parallel to the limbus is a very good technique, where although you want a long tube in children to accommodate for the growing eyeball with age, you don't want it to come towards the pupillary axis and cause a problem. So because in children, whatever you do, this eye rubbing is something that you cannot completely avoid. This patient required a tube trimming. It's quite easy to do that if you have this micro forceps and a micro scissors, you can go and trim it. Corneal decompensation, again, a very important lesson for us to learn. Like I said, although the tube is not touching the cornea, we know that it is a dynamic thing. Each time you're trying to close and open the eye with the lid squeezing on the cornea, the relationship between the tube and the cornea are not constant always. Sometimes they keep coming and opposing, especially if there is a decrease in pressure. That means when there is a hypotonia or low intraocular pressure, this is more common. This patient was doing quite well, but required although there was no tube corneal contact, required a desec because the cornea decompensated. Sometimes like this it can happen. We have to be very careful when you're inserting the tube in the anterior chamber that you don't make a track in the cornea. Always the track that you do, when you reach the limbus, you have to dip down so that it doesn't make a track in the cornea, because corneal track can cause problems like this. We need to be careful. So tube retraction is another problem, because especially in children, this was one of the first children that I had operated with aniridia. You don't want a very long tube going and touching the lens because it's crystalline, and you don't have iris to go and support it. And lens is crystalline, so I didn't want to do it in the pars plana. So when we tend to really don't leave a very long tube. Nowadays, if I have to do this patient now, I would do it in a completely different technique where we leave a long tube parallelly to the limbus on the zonule so that it doesn't even reach anywhere close to the lens. This child had a tube retraction, and a couple of other children, especially with aniridia, you can use a tube extender. It's not that you have lost the implant. If the implant is functioning well, you can use a tube extender to save the implant. This is a very interesting complication that I noted. One of the patients who was referred to be a dynamic tube. That means the tube will go into the subconjunctival space, and as the patient is either looking straight or down or extreme down gaze, you can see the tube is becoming longer and getting retracted into the subconjunctival space. By doing so, the patient actually had a block of the tube because it's whenever it is going out. So we had to explant it and redo the procedure in this patient. So another interesting complication that we come across is conjunctival ischemia, because most often these eyes are mitomycin treated, and we need to be careful. So this can, sometimes medical treatment can help in these eyes, and I use oral doxycycline in these patients where the conjunctival healing can be very good. If the conjunctival defect is very small and there is no leak, most often it resolves. But if you have a large defect, we need to surgically repair it. Tube erosion is a major complication that we're all worried about, which happens in the late postoperative period. It happens usually very close to the limbus, not because you have not covered it with sclera or the cornea, but because of the immunological reaction. Sometimes even that can get absorbed. So once this happens, it's an emergency. It has to be operated either with a scleral patch graft or a corneal patch graft, conjunctival advancement, or a autograft. So it's one of the risk factors for endophthalmitis. If you have it, then we'll have to explant it, because you also know that some amount of this, the bugs are sitting in the tube, so we can't leave it there and do a vitrectomy and continue with antibiotics. If you see something like that, it's better to explant the tube. You don't have to remove the plate, but the tube has to come out of the eye. Sometimes we see something like this, where very anteriorly placed implants, not properly fixed, not covered with tubes, can have exposure of the plate. Once you have a plate exposure, I think it's universal that you need to remove the plate. There's no point in going and covering it with one patch graft, another patch graft. Invariably, it will fail. So this was a patient where we had to remove it and do an implant in the inferior quadrant. Diplopia, although it's very, very rare, but sometimes it can happen because of the large bleb face in a AGV or because of the muscle fibrosis with an RD implant. So to summarize, although we know that we are using this in compromised eyes to bring down the pressures after multiple surgeries, choosing a case meticulously, avoiding a complication, and in case you have a complication, appropriately treating it, I think will take us a long way in having better intraocular pressure control in these eyes. Thank you.